And I was shocked when I looked at her records and I interviewed her and her son at bedside, and all she was given was ibuprofen. Her son said the doctor said they didn't want her to get addicted.
The literature points that it may increase pain. It's not associated with reduction in pain scores or improvement in function.
Welcome to your daily health briefing. I'm Dr. Albert Takem. This show is here to help you navigate the complex U.S. medical system, one step at a time. Whether you are decoding a new diagnosis, fighting for a referral, or just trying to stay informed, you are in the right place. Let's get into the science. Some of the patients who suffer the most from opioid abuse are the patients who have never abused opioids a day in their lives. Because today, in medicine, unfortunately, we are caught in a dangerous tension. On one side, we are trying to protect society from addiction and drug diversion. On the other side, we are watching patients with severe, legitimate pain struggle to get relief. So today, I am sitting down with the pain management specialist, Dr. Tiffany Russ, to answer one of the hardest questions in modern medicine. How do we protect patients from addiction without abandoning patients who are genuinely suffering? Welcome to the episode, Dr. Russ.
Thank you so much for having me, Dr. Takem. I appreciate it.
So I want to tell you a story of one of my patients. Let's call her Mrs. Stevens. She's 83 years old, moved to the area from New York to be with her grandchildren and to be with her son and grandchildren. And she had multiple medical problems, which I won't go into all of them, but the ones that were the biggest problems for her was she had severe degenerative lumbar and cervical spinal disease, documented on the MRIs because I requested her records from her previous physicians in New York and reviewed them. And she had hip problems, severe bilateral hip osteoarthritis. She had already undergone a right knee replacement. She had cervical spinal stenosis, which was deemed inoperable, and she had lumbar degenerative disease, multiple levels. So this is a woman who dealt with chronic pain all day long. And I was shocked when I looked at her records and I interviewed her and her son at bedside, and all she was given was ibuprofen, 300 milligrams, or was it 400 milligrams, 3 times a day. And I asked her, well, did they offer to do any procedures? She's like, no, they said I was too old for that. And did they give you any pain relief? Unequivocally, all she got was Tylenol and ibuprofen. Because, and the key word is, her son said the doctor said they didn't want her to get addicted to narcotics. At 83. Was she going to walk down the street looking for a drug dealer to sell her Percocet? I was flabbergasted. But I may exaggerate, so I brought you here as the expert to tell me why I am wrong.
No, that's a really unfortunate story, and I see that quite often, right? The elderly is definitely an undertreated patient population. We're worried about safety, we're worried about side effects. We know that when you get older, the way our bodies kind of break down medications is different. And so a lot of, clinicians may prioritize safety and inadvertently end up undertreating that patient. So absolutely, you should always maximize, non-opioid therapies. Yes, Tylenol, yes, ibuprofen, but that patient should have absolutely been offered procedures to help with her discomfort. I say age is not a contraindication or reason as to why you can't get certain pain procedures to help with your discomfort. So that is an unfortunate story, and I see that quite often, especially in the elderly and other populations as well, who are, misheard, experience unconscious bias, and have difficulty or access into getting proper, care.
So let's talk a little bit about the narcotic angle of this opiates. Now, in other episodes, then we'll delve more into interventional procedures to relieve pain. But I want us to focus on something because narcotic pain medications came on the market to relieve pain. Doesn't it feel in medicine like we have thrown the baby with the bathwater and we're making people suffer unnecessarily for the problem that other people had with drug diversion and, opiate abuse? What's your perspective on that?
I do agree. Sometimes I worry, are we doing patients a disservice, right? When we look at the long-term literature, right, are opioids great for, chronic musculoskeletal related pain? And they're actually not. The literature points that it may increase pain. It's not associated with reduction in pain scores or improvement in function and quality of life long-term. The data just isn't there. Right? But are there, genuine patients who do require this therapy? And so we know that the CDC and the World Health Organization set guidelines for us as clinicians about when it's okay to prescribe these medications, but it doesn't take into account every patient. They're just guidelines. So patients with sickle cell disease, patients with cancer-related pain, patients with end-of-life or palliative care, right? Those are patient populations who benefit from long-term opioid use. And there are a host of other patients with chronic conditions who aren't good surgical candidates, like you mentioned, who have conditions where they're not able to tolerate anti-inflammatories. Maybe they can't tolerate taking Tylenol, or they have serious negative side effects from other medications who benefit from the use of these medications. So there's a constant balance between risk, benefit that I have to use as a clinician when I'm making the decision if it's okay to prescribe these medications for people.
So let me ask you something else. So in your experience as a physician, as a clinician, based on evidence-based medicine, of course, what qualifies as legitimate chronic pain?
So we have to define what is chronic pain. So that's pain that's been there for longer than 3 months, okay? Acute pain has been there present for less than a month, and then there's subacute pain, which is longer than 1 month, but still less than 3 months. And so,
okay, just hold on 1 second, because I'm a commuter driving to work right now, and you just hit me with
too much info.
A lot of information. Let's slow it down a little bit for the daily DC Metro commuter. What qualifies as legitimate chronic pain?
So pain is a subjective experience, and I think it's important to realize that pain is based on genetics. It's based on psychological, how we process emotions. It's also based on social factors as well. So your lived experiences, your environment, culture, all of that plays a role into defining how that person perceives pain. It's not something that I can say what qualifies as legitimate, right? Everyone's experience is going to be different.
Do we need to start believing patients more when they say they're in pain?
Absolutely. Absolutely. Again, those lived social experiences dictate how patients perceive pain. I have a number of patients with history of sexual assault, trauma, and how they perceive pain may be different than someone else. And so I take all of those things in factors into consideration when I'm trying to come up with a regimen in terms of procedures, in terms of medications that will work for that patient.
Okay. Because over the many years I've practiced medicine, I'm not going to age myself out there. I've come to terms with the fact that pain is really what the patient says it is. Right? Because it's a lived experience, as you just mentioned. And it's really up to the patient to define what pain is to them. So how do you feel about the pain scale from 0 to 10?
It's a very subjective measurement, right? But it is a way for us to objectively document. And it really comes into play in terms of insurance companies and what dictates meeting criteria in order to justify either, paying for procedures or approving medications as well. So it's important, but it doesn't mean much, right? So I want to know function-wise, how much are you moving? How much sleep are you getting? What are you doing that you couldn't do that you're now able to do? That's more important.
So the impact of that pain symptom on the patient's overall functionality as a person.
Absolutely.
Okay. So now coming back to the question of opiates, how do we differentiate between, for a patient, right? When I'm counseling a patient and I gave them a prescription for Percocet, and I'm trying to figure out whether the patient is dealing with tolerance or addiction, right? And you have to ask them all these questions to differentiate between the two. How do you think we should go about that? And how, as a patient, what do you think a patient should tell the doctor to help them understand the difference?
Tolerance, meaning you take a certain amount of medication and your body gets used to it over time. And so what you were able to take before may not be as effective as it once was. And tolerance happens really quickly with these medications. I say they're very powerful and they come with a number of side effects. And I'm constantly educating patients about that. Dependence is a totally different issue, if you will. Dependence means, maybe I've been taking this medication for some time, and if I abruptly stop, I may have some negative side effects or symptoms, right? But I'm dependent on the medication because without it, I may not be able to function as well, and I may have negative side effects that come with abruptly stopping. Addiction is, I will go out of harm's way in order to get this medication. It doesn't matter if I hurt someone else or hurt myself in order to obtain the medication. So those are three kind of separate issues, if you will. And you're right. As a clinician, I want to know about the patient's medical history because it can put them at risk for addiction and at risk for abuse. And I want to know the environment that they're in as well, because that's constantly something that I'm evaluating in terms of risk management strategy.
So if I'm a caregiver or the loved one of somebody or a patient who takes opiates on a daily basis, the things I want running in my mind, which you just mentioned, is number one, are we dealing with tolerance? Where you need to take more to have the same effect, pain relief, hopefully in this case. Or you mentioned dependence. Do I need to take this medicine to feel okay? That's dependence. And thirdly, would I go out of my way, including harming somebody, to get that medication? And that's addiction.
Absolutely.
And that's pretty much a partnership between the patient and his loved ones and the physician.
Yes, I tell patients, please be honest with me. Like, I'm your physician. You should feel comfortable telling me what's going on. And, you have to kind of establish that relationship. And that starts from the very beginning in terms of educating the patients about the medications, kind of setting expectations. What are your goals? What are your overall plans in terms of function? And just, it's a shared decision-making process, if you will.
And we also have tools as physicians, like the prescription drug monitoring program, to watch and see if there's any drug diversion, or to see if a patient is dependent or is tolerant or is addicted to a medication, including things like urine drug screens.
Absolutely. So it's a part of our office policy. We intermittently do urine drug screen testing. I'm always telling patients, hey, you're not to be taking this medications with heroin, cocaine, drinking, excessive alcohol or drinking any alcohol, right? Because it puts you at risk for negative consequences. It can affect your breathing. So
how can it affect your breathing?
Yes.
If you are the loved one, say you're the wife of a patient right now who takes Percocet and also drinks heavily, how can that affect your breathing? What should they watch out for?
Alcohol, binds to certain receptors in our body, as well as opioids, and that can cause something called respiratory depression or a lowered breathing rate. So you don't want to have multiple glasses of alcohol and take these powerful pain medications, because together it's kind of a cumulative or an additive effect. So I say
cumulative adds up.
Exactly. And that's
Straight
not
talk.
a good thing. Straight talk.
And so that's kind of why some people die in their sleep.
Absolutely. And so, yes, do I often prescribe a prescription called Narcan, which reverses the effects of the medication, right? But you have to have someone present with you that's able to see what's going on and kind of rapidly give that medication. So I always prescribe Narcan for my patients and tell their family members and their loved ones how to use that medication.
So you prescribe Narcan to anybody taking opiates on a chronic basis?
Yes.
Let's talk a little bit about the multimodal pain management approach. Because, for instance, going back to my patient, Mrs. Stevens, she did not have any of that. What would you have done differently for this patient?
Absolutely. So I say a lot of what I do starts with a history and physical. So talking to the patient, examining them, seeing how they function. Then I review the imaging. I see what's going on. And so based off of what they're telling me, based off of the imaging, I say, on my expertise, I recommend this procedure. All right. There's data to support that maybe this nerve injection or maybe this epidural will help reduce the pain that you're having, not eliminate it, but reduce it. I, recommend physical therapy. I do recommend Tylenol. I do recommend ibuprofen if appropriate, and the lowest effective opioid dose if necessary.
So you put everything on the table.
Everything on the table.
To help the patient.
Absolutely. I say it's not just injections. It's not just medication. It's not just physical therapy. It's everything together to help reduce the pain and improve function and quality of life.
Let me ask you something else that we doctors struggle with, right? Because you invariably get a patient who takes 5 milligrams of oxycodone once or twice a day. After 3 months, he calls and says, it's not working anymore. Can we do 10? Can we do 15? Can you explain to the patient or their loved one right now, listening to us right now, why dose escalation is dangerous with opiates?
It's very dangerous, right? Tolerance develops very quickly, meaning it's not going to work as it used to work previously. And I know that happens. And so there's a limit to how much we can write in general, okay? Just in terms of safety, I really try to focus on negative side effects of these medications to kind of limit people, even requesting it. And I say, what else can we do to help reduce your pain? Because I already know at the end of the day, in a couple of months, you're not going to have the same effect anymore with the medications. And going up isn't the answer, right? And long term, we know that patients can develop something where taking pain medications makes their pain worse. It's called opioid-induced hyperalgesia. So they become more sensitive to taking medications. The pain is worse. Nothing is really changing. And that's a cycle that we don't want to be in.
When you take opiates long term, it can actually make you more sensitive to pain.
Absolutely.
So instead of making the problem better, it makes it worse.
Absolutely. That is an effect that happens quite more frequently than we may recognize it. And so I really try to counsel patients, let's do everything we can to maximize reducing pain. Always take the lowest amount of medication, right? If you can take a half a tab less per day, if you're not having any discomfort, please do not take the medication. I say take a little medication holiday. Or reduce the amount of medications that you're taking in a day for as long as you can.
So could that be the reason why the patient who's taking 15 milligrams of morphine 3 times a day, which is a pretty high dose of opiates relatively, still complains that, docs, every now and then my ankle hurts. I was trying to shovel snow the other day and I twisted my ankle and it hurts real bad. But he's taking 15 milligrams of oxycodone 3 times a day.
So again, long-term use of opiates for musculoskeletal related pain is not helpful, right? Can we treat the underlying issue? Let's get some imaging. Let's make sure you do physical therapy. If there is a procedure that we can do to help target or reduce that pain, let's absolutely do that. It's not that opioids are our last resort. It's just that we really should maximize other options before we go to medication escalation.
How about red flags for drug diversion or addiction? How can we help family members watch for these? What should they be looking out for?
So I tell patients you need to make sure you put your medications in a safe space. No one should have access to your medications unless they're not able to, certain elderly patients, their family members may be administering the medication. I want to make sure that they are following the directions on the bottle, right? If you are running out 2 weeks before your next appointment date, that means you're not following instructions, okay? You're more likely to be at higher risk for abuse and misuse because you're taking more than what I have directed you to. I want to make sure they are, again, not consuming alcohol, okay? I look at their medical history. What other medications are they taking that are habit-forming medications?
So what can the spouse or the loved one of a patient who takes opiates on a chronic basis for pain management do to prevent them developing addiction or dependence?
That's a tough question, but I think their spouse or their loved one can help keep the patient accountable, okay? They should be in the office visits. They should be hearing the same risk of taking the medication that the patient already knows and just really keeping that person accountable, right? They can't prevent, anything, right? It's up to the patient to kind of make that decision, but they can help keep the patient accountable.
Because I've had a patient where I told him, the only way I'm going to continue prescribing this is if your wife is the one giving it to you, right? You tell her when you want it, when you need it, and she will evaluate the pain. And I told the wife who was in the visit, all the signs and symptoms, the red flags for drug addiction and dependence. So she should watch out for those. And she did. And she actually was the one who came back and told me that I shouldn't give him any more.
Wow.
That she thinks he's misusing them. And
so even with that structure and control, right, she was able to still identify a problem. And so, again, addiction is a really kind of complex topic. And so I'm always paying attention to red flags. Psychiatric history plays a role. History of sexual abuse or trauma plays a role. Genetics plays a role as well. So
to wrap up here, we started out with the story of Mrs. Stevens, who had legitimate chronic pain and was not heard and was not treated by the healthcare system because of the fear of drug misuse. You just told us all the other things we can do for pain that does not involve opiates, but also that opiates are part of the treatment, which brings me to the conclusion that doctors just have to be doctors. You can prescribe an opiate, but you have to monitor the PDMP, the Prescription Drug Monitoring Program. You have to monitor urine drug screens. You have to talk to the patient's families. You have to treat the patient's pain with everything on the table, but also watch out for the patient so they don't develop dependence or addiction. You just have to be the patient's ally.
Absolutely. I wholly agree with what you're saying. And so that's a part of what I do every single day on a day-to-day basis.
And that's what we do on this show. We are the patient's ally, helping them navigate the complex healthcare system they live in and we all live in. Thank you, Dr. Russ, for joining me on this episode.
You're absolutely welcome.
This has been the Daily Brief. Medicine is not about certainty. It is about responsibility. Decisions are often made with incomplete information, but they are always made with your safety in mind. In a system that can feel rushed and fragmented, you deserve clarity, continuity, and an advocate who sees the whole picture. I am Dr. Albert Takem, your physician ally, high-level science, human-level care. I will see you at the next briefing, or I will see you in the clinic.